Welcome to the Homegrown Heart Podcast, every Friday at 7 a.m. Mountain Standard Time with your host, Dr. Amanda Ryan, DO, MBA, interventional cardiologist, and a recognized expert in her field. This week's topic, the different types of stress testing. Help me welcome our host, Dr. Amanda Ryan.
Good morning, Carlsbad, Eddy County, surrounding areas, and our listeners in Florida and Illinois, Missouri, all the places we've lived and been. This is Dr. Amanda Ryan, your friendly interventional cardiologist. And this morning I'm going to talk about different types of stress tests. I'm also on call, so if you see me looking at my phone a little bit, it's to make sure that I'm not missing anything. Any critical phone calls, and it has been that kind of week where I might have to rush out and do something. So, stress test. What are stress tests? That's what I'm really going to talk about this morning. What are the different kinds of stress tests, and exactly when do you need which kind, and your physical capabilities and symptoms might dictate what kind of stress test is appropriate for you. I will say I tell patients a lot of this about stress tests, that I relate to being a woman that tells someone you're pregnant. And when you do, all of a sudden you get every terrible pregnancy story or outcome that somebody has had. And I say that with a smile, not because it's not devastating, and I have several of my own heart-wrenching pregnancy stories that someday we'll share. But just the idea that you tell somebody that you're going to get a stress, they're like, oh, my grandpa's best friend, they put him on a truck, he died. And I'm just kind of like, okay. Well, I'm going to, oh gosh, I definitely need to knock on some wood for this, but I've never had a bad outcome of that severity on any patient that I've ever put on a stress test machine. And a lot of that is probably good patient selection. I always tell people that my skills are average, maybe slightly above average, but my judgment is spot on. And good judgment has gotten me a very long way in life and as a physician. Now, my aunts and uncles, the family members that might be listening, my teenage judgment was not always spot on. Okay, so we'll say I've learned over the years. I saw a good meme last night about that did kind of say, when you see people that haven't evolved very far, that kind of reminds you of that you've been different places and that you've kind of evolved. Not to judge people, because I think we're all at different places in life. But one of the things, again, mentoring young women, particularly from difficult socioeconomic or family structure backgrounds, is one of my greatest passions in this world. And sometimes I see them they're just all at different points of really trying to get the most out of life, to really achieve what I think they were put here in order to do. And sometimes just instilling the confidence in them, helping them see a path. Again, I'm jumping around a little bit, but I saw a person, one of my patients yesterday, who I'm super proud of. My medical assistant came out also very proud. The patient has lost 100 pounds so far. And they're very young, like in their late 20s. And she's very proud of herself. And I mean, she was weighing about 450 pounds. And it was really impacting her life. Blood pressure, diabetes, a lot of different issues. And she really decided, has no children, wants to have children. Her doctor, I'd really talked to her like when we're talking about healthy pregnancies and healthy futures, and you're diabetic and you've got high blood pressure and these things. With the 100-pound weight loss, she's already off every medication. And I told her, she's like, it's an up and down. Sometimes you're like, wow, I'm so proud of myself. I'm not where I was, but I'm not where I want. She's like, 180 is her goal weight. And in her mind, she's like, I'm still almost twice 180. I'm like, you got to focus on the fact that you've lost 100 pounds already. She's walking 3 times a day for 10 to 15 minutes. She's got her dog. She's walking her dogs. She said her quality of life is just dramatically improved. But as I talked to her about seeing herself, where, she's like, I'm a little scared to, get some of these plateaus and stuff because I haven't really. She's like, I feel like I made the decision and the decision was hard and sticking to it was hard. But she said, I've gotten the results by the weight continuously coming off. I'm off medications. I'm feeling so much better. She basically is like, I just don't want to lose that momentum and I'm afraid a plateau might do that to me. And I said, you kind of have to envision yourself, think yourself where you see yourself where you're trying to get. Appreciate where you are, respect where you've been, but envision yourself where you're trying to go. And that doesn't matter if it's weight, if it's career, if it's a family situation, if it's any of those things. In order to achieve things, you really have to believe in yourself. And in order to do that, you got to visualize where you're going. And so that was a really powerful patient visit that I wanted to share with you guys, because sometimes it was also a very stressful day and there was a lot going on. And in some ways there was negativity with outcomes, and it's just been a really tough week on some of our younger patients not having the outcomes that we wish they would. And I'm sending prayers out to a few specific families who do listen to my podcast and know I'm talking to you. I love you, and may God wrap his loving arms around you and your families during these times of true sadness and loss. But to also have those quote unquote wins, and being a physician is not a game, but there are wins and losses sometimes in your emotional ups and downs in caring for people and trying to get people invested in their health. And seeing this young woman so excited and with a new lease on life, it was just very uplifting to me yesterday. So God puts people where they need to be when they need to be there. That is how I feel. So back to stress test. So outside from everyone having some crazy story about how somebody had a bad outcome with their stress test, when they're chosen appropriately, very low likelihood to have a problem during a stress test. I want to talk about who gets a stress test. People that have chest pain that we think might be heart related. A lot of patients come to me because they have an abnormal EKG. What is an abnormal EKG? Now, this is also a reason that we try hard to get patients into our office within 2 to 3 weeks. Again, it's common for a cardiology practice to take 6 to 8 weeks to get patients in. In a lot of our subspecialty practices in our area, because of our shortages I've discussed, it's not uncommon to take 6 to 9 months to get into some of our specialists. If you're a patient, potential patient, you're 54 years old and your doctor told you, oh, your EKG is abnormal, you need to see a cardiologist. I acknowledge, and I've learned over the years, it's very stressful for people. I get 15 referrals a day for abnormal EKGs. I tell people they're a $10 approximately screening test. It is a glimpse in time of what's going on with the electrical activity in your heart. It's related to your intracellular potassium and magnesium and sodium levels and stuff. So sometimes getting dehydrated, different electrolyte shifts. There are lots of things that can make an EKG quote unquote abnormal that don't have to be a serious heart problem. But sometimes an EKG is abnormal and it does imply a serious heart problem. That's where your friendly cardiologist and our team come in to help figure out, is something on your EKG, especially if you have any symptoms, is this concerning from a cardiac standpoint or it isn't? So in trying to sort that out, basically, you'll come to our office. By the way, we always like to get our own baseline EKG. And I think some people are like, well, I just had one 2 weeks ago in my doctor's office. And I'm like, I understand that. sometimes based on where they put the leads, or again, glimpses in time, what your blood pressure was at the time, your potassium levels, different things could have affected your EKG. So we in the hospital, if somebody comes in with active chest pain and we might be concerned that they're having a true cardiac event where they have an acute blockage, we might do 5 or 10 EKGs in a day on that person. So it's not uncommon to get lots of EKGs on people. And as a matter of fact, when you get a stress test, there's a continuous EKG strip running the whole time you are either on a treadmill or 3 minutes after you get a chemical injected to stress your heart, for those of us that can't walk on a treadmill. So if you come in, you have this abnormal EKG and any kind of symptoms, that could be short of breath, that could be arm heaviness, that could be chest pressure, that could be jaw pain, could be a lot of different symptoms, can imply blockages or heart issues. We often might recommend a stress test for you. The simplest kind of stress test is to put you on a treadmill, hook you up to an EKG monitoring, and constantly monitor your heart's electrical activity while you get up to peak exercise. Now there's a thing called a Duke treadmill score. Years ago, treadmill stress tests were studied. It's fascinating to me to think that some of these guys in the late early 1900s were able to figure this kind of stuff out. But they could figure out if we put you on a treadmill, every 3 minutes the treadmill went higher and faster. So some people I tell people you'll probably be on a treadmill, 6 to 10 minutes. Everyone's like, oh, that's no big deal, etc. The treadmill goes higher and faster every 3 minutes. So the first 2 stages are usually fine for most people, but after that, it gets pretty difficult. But it is specifically designed based on how many METs, it's called. So basically how many metabolic exercise units you can do based on your age, how long you're able to do the treadmill, and if your EKG changes or doesn't change. So basically using that information, we have a very good predictive score of your not only immediate risk of heart problems, but your 5-year risk of heart issues as well. So a treadmill stress test called Bruce Protocol has been around a long time, well studied, and very useful. Unfortunately, it's not perfect. There are a lot of false positives on exercise stress test, especially in our 40 to 60-year-old women in particular. So somewhere along the way, we realized, well, we have some false positives, some false negatives on just this treadmill part. So maybe we should add pictures to the EKG part to increase our sensitivity and specificity of our test. That's when, about that time, we had evolving technology in the nuclear world as well as the echocardiogram world. So as far as nuclear stress testing, the way it works, and this is a simplistic explanation, but you get pictures at rest. You then get on a treadmill, or for patients that can't get on a treadmill, they get a chemical that quote unquote stresses their heart and makes their heart's arteries get larger. What I tell people is either exercise or this chemical. If you have a blockage, if in an artery, maybe that artery only gets this big, that's the right hand. The left hand, the other artery without a blockage is the left hand, it gets this big. We inject a small amount of nuclear tracer then, not enough to hurt you, but this artery takes up more nuclear tracer than this artery does, okay? I see a difference in the post-stress images. Your heart on a nuclear stress test, which we'll show an example, gets cut like a loaf of bread and has multiple different colors. It looks like colors of the rainbow. And when we learn how to read those, what we are looking for is dropout of color when you're at stress compared to when you're at rest. That would imply that you have a significant blockage. Now, if you've had a heart attack and suffered damage to your heart at some point in the past, you might have dropout of color at rest and at stress. That doesn't show a new blockage, but it's probably just showing us that you've had an issue in the past. So that is how a nuclear stress test works. It can take up to 4 hours. You get the pictures, you do either the stress or the chemical, you go get something to eat. That allows you to take up some of that tracer from your GI tract and make sure that doesn't get in the way of our pictures. We give you a time to come back. Excuse me, just a minute. So if you've already had a blockage in the past, then again, you might have that dropout at both rest and stress, so not necessarily something new going on. So that's really what a nuclear stress test is designed to look at. Now, sometimes our breast as ladies can get in the way of a good stress test. They can have uptake. Sometimes, again, the GI tract can get in the way. So I tell people, stress tests have about 85 to 90% sensitivity specificity, but they don't have 100%. Again, the 100% gold standard answer, no matter how great a lot of non-invasive testing we have is, continues to be an angiogram or heart catheterization. That's the only way to 100% look inside your arteries. A nuclear stress test, again, is trying to pick up a blockage of 65, 70% or more. It may, in fact, miss something less than that. And an interesting case we had this week on our call, too, that's relevant. If you have blockages in all your arteries, your EKG might look pretty normal. Your stress test, that nuclear stress test I just described, might look totally normal. And the reason for that is it's looking for a difference. If all arteries are this size, they all take up the same amount of tracer, and your stress test does not look any different. I've had a few patients that I said had a normal stress test, and they ended up having cardiac events within a few months and saying, well, that doesn't make sense to me, Dr. Ryan. And I'm like, I get it. Because now, interesting, both of them were mowing their lawn, which I've made it my whole life without doing, and maybe that's why I haven't had a cardiac event yet. But no, they were both mowing their lawns, really exerting themselves in the New Mexico summer sun, and both had acute cardiac events. Now, you could have just a 40-50% plaque that wasn't picked up on a stress test. When you really exert yourself for some reason, that plaque can break off the wall of an artery, attract your body's own platelets, and you can have an acute heart attack. So a normal stress test is helpful, but again, it is not 100%. And even if you've had a quote-unquote normal stress test within the last year, but you have gripping symptoms, chest pain, and you're sweaty, you've got to call 911 and get that checked out. Even if you've had an angiogram that showed moderate blockage and you all of a sudden get more symptoms, you have to go get that checked out. So again, we talked about the exercise, treadmill, EKG part. We've said that sometimes use a chemical. Now, by the way, if we use a chemical, that EKG part, we still do hook you up with it and stuff, but it's not really as studied or probably accurate in that instance. So we're really relying on those pictures in that instance and that type of stress test. There's also something that we have at our office, which we're providing for our county and surrounding areas, which is great. We have an outside company that comes in once a month and does PET nuclear stress tests. This is particularly helpful for people that have had a heart attack in the past or are larger patients that might have a large chest or abdominal girth or large breast. It really is the latest, greatest technology combining PET and nuclear. It has less than 0.1% of false positive and false negative, which is great results. The issue is getting insurance coverage for it. Slowly coming around. Blue Cross of New Mexico just partnered with this company in the last month. So I think we're really going to be able to provide. They come to our facility, they bring a trailer, it's a fancy trailer, and it's a really great setup and a great test. I love the technology. So we have that available once a month, and as they increase their insurance options, then we really look to be utilizing that test more because it has very accurate results. Another option is using ultrasound technology, echocardiograms. We often get a resting echocardiogram on our patients that have an abnormal EKG or chest pain or any kind of cardiac symptoms. That is a structural assessment of your heart, where stress tests and heart caths are designed to look for blockages in those heart arteries. Echocardiograms are designed to structurally look. Do you have a strong heart? Do you have leaky valves? Do you have any anatomic issues with your heart? That's really what an echo is designed to do. Now, a stress echo is available. We can look at your heart at rest. On that instance, we're particularly looking at the walls of your left ventricle. That's where the 3 heart's arteries are supplying the heart's main pumping chamber. Again, that's your left ventricle. You will get on a treadmill, get to peak exercise, and then we will quickly put the ultrasound probe back on you, and we'll see if one of the walls of your heart is not pumping well at peak exercise. If it isn't, that implies you have a blockage in that territory. Again, that's called stress echocardiograms, and we are able to provide those at our office now as well. So there's several different kinds of stress test modality, but what you need to understand as a lay person in particular is that you'll have a stress modality that will either be walking on a treadmill, or if you can't, can be a chemical. If you're young and relatively low risk, you may just get the EKG part and the treadmill. That may be sufficient. That's often what WIP wants that once a year for a lot of their employees. Anyone working underground, the firefighters and policemen do that once a year. So occupational, a lot of times, will want truck drivers, DOT physicals. They'll want that treadmill stress test on people once a year to help assess your cardiac risk. Excuse me. Then if you're a little higher risk, or as we get a little older, again in that 40 to plus range, we'll probably recommend an imaging modality as well. That can be echo, it can be nuclear, it can be PET nuclear. So there are different options of stress tests depending on you, your risk factors. I always tell my staff this, they love some of my crazy things from training, but there's a theory called Bayes' theorem. Bayes' theorem is kind of telling you that the appropriate person to do a stress test on has intermediate risk with intermediate symptoms. That is the person that you're likely to get the most true positives on and true negatives on. You want to try to avoid testing people that there's going to be too many false positives or too many false negatives. So I somewhat tell my staff, again, if it walks like a duck and quacks like a duck, it's probably a duck. If you have diabetes, you smoke, you have high blood pressure, you have a family history of heart disease, and you have chest pain when you walk from here to that door 5 feet away, I don't need a stress test on you to tell me that you probably have coronary artery disease. Your pretest probability is about 95%. If your pretest probability is 95%, you need an angiogram so I can see exactly what's going on with those heart's arteries. It is an invasive test. Invasive tests do come with risk, although they've gotten safer and safer over the years. At this point, less than 1% of the time does anyone have a problem with a routine heart catheterization. So that's the person I would probably forego a stress test and go right to an angiogram on. On the same token, if you're 25 years old and you're healthy and you go to the gym every day and you walk 2 and 3 miles and you get no symptoms and you have chest pain whenever you're arguing with your mom, your chest pain is probably not heart related, and I probably have more of a chance of getting a false positive stress test on you than a true positive or a true negative. So you might not be the right person that I'd want to do a stress test on. So that's kind of how we're risk stratifying people, trying to decide which test is appropriate, which one isn't. The further I get in healthcare and medicine, and as far as time goes, I'm trying to be more and more in tune with what creates anxiety as a patient. The way you experience healthcare, which again, I feel like is good in America, but there's a lot of room for improvement. When I look at ways that my practice and our practice can really contribute to improving the way people experience healthcare, one way I think is to demystify it, to make sure that you fully understand it. Now, I'll be fair, some patients like tell my wife, look in the computer. I don't need to know exactly what's going to go on. Just go ahead and do it to me. But that's not a reasonable approach to your health care. It's also not really a fair position to put our healthcare providers in. If it's, again, you think you're coming, sometimes for our procedures in the surgical center, we've said this recently, unfortunately, it's like people think they're coming for a spa appointment, and we've definitely tried to create a wonderful environment in our surgical center that is as little quote unquote medical as possible, but you're not there for a spa treatment. You're there for a diagnostic or interventional procedure to try to identify heart or leg disease and or fix those problems. There may be some pain, discomfort, stress involved in those experiences. And while we are committed to making it the very best experience that we can, I just had a patient the other day that I felt like his problems with his veins were beyond what I could handle. We have an excellent interventional radiologist in El Paso, Dr. Galib, Melhem Galib, who is doing amazing work with helping me get some of these clots out of people's veins in their legs that have been in there for years, and really helping stent open their veins so that maybe they can have less swelling, they're getting sores on their legs and more blood clots. But I just kind of had a rendition of a story from a patient that he had to lay on his stomach for the procedure. He got minimal to no sedation. He was bleeding heavily during the procedure. They had to apply pressure to the back of his leg for 30 minutes. He's bruised significantly when he's in my office, etc. And he's, he's like, I asked Dr. Levy, he said, yeah, we don't give much sedation because the risk, by the time the procedure's over, you're already out, and the risk of sedation we've realized isn't really worth it. And the patient was like, well, did I bleed some because I was on heparin? And yes, heparin is a blood thinner. We're trying to get open clots and remove clots that have been there for a long time. Like, we're intervening on a disease process that a person has. We didn't create the disease process. We're doing our very best to treat it. But unfortunately, sometimes there is a little bit of discomfort that goes along with that. And we do our best to minimize it. But also, as a provider, we have to decide the potential risks and the potential benefits. So if you're some people, we are concerned that the risk of sedation is higher than the risk of the procedure or any discomfort you might feel. So we have to try to balance that for sure. So with that being said, I hope we learned a little bit about stress tests this morning. And each segment in the next couple months, we'll continue talking about various topics in the cardiovascular health world, and we hope to see you next week.